And welcome back to part 2 of the high-risk newborn. Care of the drug-dependent newborn. Drug-dependent newborns require, should we say, patience on the part of the nurse. It requires a lot of understanding and a lot of serious patience. Maternal drug abuse can be from illicit drugs, it can be from tobacco, it can be from alcohol. And I'm going to tell you all that there's increasing amounts of moms who take prescription pain medicine for chronic pain, chronic back pain, chronic whatever kind of pain they have. But the incidence of that has increased dramatically over the years. And that is also causes babies to become drug dependent. What we know is that these drugs and chemicals rapidly and readily cross the placental barrier and enter the fetal system. As a result, infants born to drug-abusing mothers are likely to experience the same signs and symptoms of withdrawal as any user with rapid interruption of use. The goal of nursing care and caring for drug-dependent newborns is to provide comfort, compassion, and restore normal growth and functioning. In addition, the nurse must take on the role of counselor or supporter for the mother and or parents. So what are the risks to the newborn of the drug-abusing mother? Hypoxia, because the abusing mom has a higher likelihood of abruption, preeclampsia, etc., things like that. Infection, due to hepatitis B, HIV, or herpes. Moms who abuse heroin often have small for gestational age babies. Moms on methadone may have large for gestational age babies. These babies are also at higher risk for having respiratory distress due to meconium aspirate, usually again due to hypoxia. They can also experience TTN, or that transient tachypnea of the newborn. These babies experience jaundice. Preemies are even more disposed to jaundice than the term baby, and most drug-abusing moms will deliver early. They are at risk of congenital anomalies because drugs can cause microcephaly, IUGR, genitourinary defects, SIDS, poor behavioral state organization, which basically means that babies can't move smoothly from sleeping to awake, and they can't handle stimuli at all. Withdrawal symptoms usually begin within 24 to 48 hours, but it can take up to 2 weeks to present. Withdrawal symptoms include irritability, a high-pitched cry that really, I'm not kidding, it makes you want to pull your hair out. Tremors, poor feeders, and by poor feeders, I mean these babies will scream and demand food, and you go, okay, fine, here's a 2-ounce bottle, drink it all, go ahead. And no, they'll drink like 10 mLs and then they fall asleep and you cannot wake them back up again. And that's a poor feeding. Vomiting, diarrhea, poor suck, and nasal stuffiness. Not to mention, there is a condition that NICU nurses call drug butt. They actually call it a little bit worse, but we'll just stick to the PG version and call it drug butt for the purpose of this slide. And basically what it is when the drugs are being excreted, they are so acidic that it causes severe breakdown. And it's just constant diarrhea that just seeps out of the baby. So it makes trying to keep their little heinies clean and dry next to impossible. So they're going to need some very severe they need a very good type of ointment and balm to protect their perineal area from drug butt, basically. So what kind of treatment should you expect from the newborn? Well, the physicians will usually order urine and meconium drug screens, so those will be collected and sent off. Social services will be consulted. Usually a newborn crisis assessment will begin, and then they will begin the neonatal abstinence scoring system. Non-pharmacological treatment for the drug withdrawing newborn includes the use of pacifiers, swaddling them, putting them in a minimal stimulation environment, use a very gentle formula And by gentle, we mean something that's going to be very easy on the gut, and then giving them a lot of butt cream. Again, I know I talked about it on the last slide, but the drugs are just so toxic and they're so acidic that when the babies poop them out, it literally eats their skin raw until it bleeds. And there is nothing sadder than seeing a bleeding diaper rash. It's like constant diarrhea. Am I painting a clear enough picture for you guys? It's extremely hard to keep the area clean and dry. Butt cream is very important, as is tea bags. The tannin in the tea helps the skin toughen up and withstand the assault of the toxic drugs that the babies have to poop out. Pharmacological management for babies who have high scores on the neonatal abstinence scoring system, then we can sometimes, and it depends on what the mom was taking while she was pregnant. Sometimes we give the babies phenobarbital, and we've also administered liquid morphine to babies as well. So on the neonatal abstinence score sheet, the nurse assesses every category, and you basically add up all of your points, and then the neonatologist will, assign treatment based on what the score is. So for scores greater than, say, 15, they will treat, by this method. For scores greater than, 20, they will treat by this method. And then conversely, as the scores start to come down, as the babies, are transitioning and going through their drug withdrawal, then they will start cutting back on the dosage of either the phenobarb or the morphine until they can hopefully get the baby weaned off completely. Fetal alcohol syndrome is the leading cause of mental retardation or cognitive challenges. It also causes children to have hyperactivity and poor coordination. In addition to the behavioral and cognitive challenges, as well as their developmental delays, infants born with fetal alcohol syndrome also experience profound growth restriction and require intensive care treatment. As a result of the CNS dysfunction associated with fetal alcohol syndrome, these neonates are often poor feeders. We've talked extensively about what that means. They have delayed coordination with very little interest in oral feedings. Fetal alcohol syndrome and drug-dependent newborns experience a number of challenges in the first few days, weeks, and even months of life. They are likely to experience chronic feeding problems, unpredictable irritability, delayed or abnormal neurologic responses, and impaired parent-infant interactions. They have very distinct facial features, and those are listed for you on your PowerPoint slide. Cocaine babies. They are generally poor feeders. They have a very poor suck. They are lethargic and they have low tone. They have a weak cry and difficulty waking. Or they can flip the other direction and have a very high-pitched cry, hypertonicity, rigidity, irritability, inability to be consoled, and intolerance to the change in routine. They can really kind of go either way. Meth babies, you can read about the problems that they have on your slide. Pot babies, they just experience a little bit of decrease in fetal growth, which is interesting because pot generally makes people hungry, yet it makes the babies not hungry and they don't grow as well. It is difficult to pinpoint more effects of pot babies because mothers don't often only smoke pot. They often take other drugs as well. Moms who take SSRIs for depression are also at higher risk for their babies from withdrawing from that too. OBs must carefully weigh the pros and cons of meds that moms take while they are pregnant. Hemolytic disorders occur when there is blood incompatibility. If it's an Rh incompatibility, it occurs because the mom's blood type is Rh negative and the baby inherits a different gene and baby is Rh positive. Generally, this does not affect the first pregnancy, but with subsequent ones, it will. Mom's blood will basically attack the baby's blood, and that causes massive hemolysis of the baby's red blood cells. And if you don't have red blood cells, you don't have trucks to carry around oxygen and tissues die. So it really is a very big deal. Moms must take Rogam, and that will suppress and keep her blood from attacking babies. It's all good. Rogam is a game changer. It saves lives, literally. Sometimes they can do a fetal blood transfusion while the baby is in utero, but again, this is a very risky procedure. ABO incompatibility occurs when mom is type O and the baby is either A, B, or AB blood type. This reaction is less severe than the RH incompatibility. The most common manifestation is jaundice before 24 hours of age. Babies can get an enlarged spleen, hypoglycemia if the pancreas gets involved. They can also become anemic. They do a Coombs test on the baby's cord blood after birth if the mom is blood type O to see what the baby's blood type is going to be. In rare cases, for severe hemolytic disorders, they can do what's called a blood exchange transfusion as well. Infant of a diabetic mother. The single most influential factor in the well-being of an infant of a diabetic mother is the status of the mother. Essentially, neonatal hypoglycemia, as it pertains to the infants of diabetic mothers, is a transient state of hyperinsulinism. If the diabetes is poorly controlled, you end up with very macrosomic, very ruddy, these babies look very red, and excessive adipose fat. These babies usually have a very thick umbilical cord. Look at the cord in this picture on this baby. It is a fat, juicy cord. They can also have excessive weight due to the increased weight of vital organs. So it's not just, these babies are fat everywhere. Their organs are heavier than they should be. Their skin is stuffed with fat. They are fat everywhere. The excessive weight is due to the increased weight of vital organs, not fluid retention. In reality, insulin-dependent diabetic mothers have a decreased volume of body water. Thus, infants of poorly controlled diabetic mothers experience a number of acute and long-term complications. Complications of the infant of a diabetic mother. Hypoglycemia. Basically, you cut the baby off from the mom's high sugar supply, and so the baby's going to end up with low blood sugar. They also have a less ability to release glucagon and catecholamines. In the clinical setting, the AAP recommends that serum glucose levels be maintained above 40 milligrams per deciliter. In addition, each facility will have specific recommendation or algorithms for routine screening. Hypocalcemia, this is what causes babies to have little tremors or to appear jittery. This can be caused from the stress of labor and birth, can be caused from prematurity, and it can be caused from diabetic moms because they tend to have a lower serum mag level secondary to the increased urine calcium excretion, which causes secondary hypoparathyroidism. Wow, if one thing leads to another thing, leads to another thing, leads to another thing example. Vitamin D antagonism from elevated cortisol levels, hypophosphatemia from tissue catabolism, and decreased serum mag levels. Wow, that's quite the cascade of events. Hyperbilirubinemia, again, these kids are a little on the dry side already when they come out, which is just going to increase their hematocrit, so that puts them at a little bit higher risk for having jaundice too. Birth trauma, big kids are hard to pop out, so shoulder dystocia is common. Polycythemia, fetal hyperglycemia, so baby's still inside mom, swimming around in there with hyperglycemia, and hyperinsulinemia, so because the baby's getting too much sugar, The baby's pancreas overcorrects and kicks out a lot of extra insulin to compensate for that. But that process uses up a lot of extra oxygen, which causes hypoxia, which stimulates the baby to make more red blood cells, because that's what the body does. If you don't have enough oxygen, oh, well, we'll just go back to the car factory and make more trucks. So it goes back to the factory and tells your, body, make more red blood cells. We don't have enough. Respiratory distress, because insulin antagonizes cortisol-induced stimulation of the lecithin synthesis necessary for lung maturation or maturity. Also deficient is a phospholipid, which is needed for surfactant. Infant of a diabetic mother. These babies also have a delay in the closure of the patent ductus arteriosus, or PDA. Birth defects include congenital heart defects, PDA, the patent ductus arteriosus, transposition of the great vessels, renal anomalies, neural tube defects, or a small left colon. So now we'll change gears a little bit and talk about some common cardiac defects in babies. The most common cardiac defects are seen within the first 6 days of life, and those are listed out for you on this slide. Possible causes of cardiac defects like this could include environmental triggers, genetic triggers, exposure to rubella, CMV, or the Coxsackie B virus, and/or influenza. Steroids, alcohol, lithium, and anticonvulsants are also implicated. So is pesticide exposure. We also see cardiac defects also in babies who have Downs, Turner syndrome, Holt-Oram syndrome, trisomy 13, and trisomy 18. The heart defects may include the cardiac septum, heart valves, arteries, and veins. There are 7 common anomalies which fall into this class. Other congenital anomalies that do not fall under the critical congenital heart disease category include the patent ductus arteriosus, ventricular septal defects, and coarc of the aorta. While these conditions do present significant challenges to the neonate, they are not what we consider ductal dependent and therefore are less catastrophic. In addition, these conditions might resolve on their own and do not always require surgical intervention. As the 7 heart conditions listed above, they will require surgery and intervention. So the 3 most common manifestations of a cardiac defect include cyanosis, a heart murmur, and signs of congestive heart failure, such as tachycardia, tachypnea, diaphoresis, cardiomegaly, and hepatomegaly. If cyanosis occurs in the first 12 to 24 hours and there is no apparent respiratory distress, think cardiac. Something's going on with that baby. Now, a lot of congenital heart defects can be detected with doing a simple pulse ox screening at about anywhere from 24 to 96 hours of life. They put pulse oxes on in pre and post ductal and then look to make sure that the numbers are only within 1 to 2 values different, but they should be pretty close to the same, if not the same. Congenital anomalies are the leading cause of neonatal death, followed by prematurity, and are present in anywhere from 2 to 3% of all live births. Congenital malformations therefore account for about 20% of all neonatal deaths. And some of the ones that we see the most common are listed for you on your slide. This is always a great slide to show students, and it always usually creeps people out. At omphalocele, this is the difference though. An omphalocele is herniation of the abdominal contents into the umbilical cord. Look at that top picture. Do you see how there are abdominal contents inside the umbilical cord? This is in contrast to gastroschisis, in which abdominal wall defects allow protrusion of the guts, basically, to migrate outside of the body. The umbilical cord is intact. So the guts are leaving. The umbilical cord is just to the side. There's a hole that goes into the belly, and it's just to the side. We don't see a lot of cases of omphalocele in this area, but we do see quite a bit of gastroschisis. Diaphragmatic hernia is another congenital anomaly, which basically just means you have the protrusion of the intestines into the thoracic cavity. You should not have stomach contents in your thoracic cavity. Myelomeningioceles also occur. And then another big anomaly would be an imperforate anus. So there is a significant increase in the fetal and neonatal mortality in post-term infants compared with term babies. Post-term babies account for anywhere from 3.5 to 15% of all pregnancies. These are the babies that are born after 42 weeks gestation. Potential intrapartum complications are listed for you on this slide as well. So post-maturity syndrome. Again, this places the neonate, infants who have this, for hypoglycemia because of the nutritional deprivation and depleted glycogen stores. Any glycogen stores this baby was able to put down, they have now since lost. Hypoxia due to the likely meconium aspiration becomes a risk because when babies become hypoxic, what do? We've been over this before. They poop. They get hypoxic because the placenta gets old. Severe MEC aspiration increases the risk of the baby developing PPHN, which is a persistent fetal circulation pattern. It also increases their risk of developing a pneumothorax and or pneumonia. Polycythemia, in response to the hypoxia, their body says, well, we're hypoxic, let's just go make more trucks. So they make more red blood cells. Seizures due to hypoxic states. Cold stress. This is crazy. Why in the world would a post-term baby experience cold stress? And that's because post-term babies tend to lose weight in utero, either because of the loss of or the poor development of fat. And then the other big thing is look at their skin. See how this baby is peeling so much. Their skin becomes like parchment. Fingernails on a post-mature baby are usually very long. The babies appear very long and lean. They don't usually have a lot of fat on them, so they're going to have problems regulating their temperature. If the baby released its meconium in the womb, say days or even weeks before they were born, then when the baby is born, the nails and the umbilical cord may be stained a green color due to the meconium release. So the nursing care for a post-term baby is really not that much different than you would provide for any other baby. You will continue to monitor their cardiopulmonary status, keep them warm, monitor labs. You will assess them for birth traumas such as complications from cephalopelvic dysfunction in the mom, especially if the baby is LGA. You will assess their skin. It's important to tell parents do not pick off like a sunburn and flake off their new baby skin. Just let it slough off on its own. And then I already told you would assess for birth trauma. And this concludes part 2 of chapter 25.